Okay, now I can record, and I am recording. Okay. I'm the host, and I'm recording. So that's good. All right. Okay, now maybe I can share my screen better too. Let's go back and do that and see if I can get. Okay, well, Isabel was doing a fine job, so we'll ask her to do it again if I can't. No, my access is still denied. That's so weird. Okay. Yes, Isabel, would you mind sharing your screen again? Are you, if you're there?
Yeah, of course. Just give me a second.
Okay, sure. Yes, I'll give you as much time as you need. All right. Okay, so we talked about communication. For the time being, for the next few days anyway, let's do email. Whenever I get a telephone number, I will give it to you. Yeah, scroll down for us now to the next page. This shows the prerequisites, which hopefully you do have them all. I mean, it's especially 344 would be really, really critical. They're all important, but if you haven't had 344, you will not be successful in this course. So I just want to make sure of that. And these are the learning objectives. So just go through those when you have a chance, if you have not done it already. We're going to basically learn all about neurology as it applies to speech language pathology. And we will go through some slides that go into more detail on that. The textbook is the 6th edition. Now I put the year, but I did get several questions about, is it the 6th, what edition is it? It's green color and it's the 6th edition. The previous edition is almost the same. So if you somehow had it, I think you could work with it. The chapters are the same except for 9, 10, and 11. I think there was a little bit of change there, but anyway, it's the 6th edition, it's green, and hopefully you all have that. You will need it. Scrolling down to observations. Oh, scroll up, Isabel, would you mind, to attendance? I'm not taking roll. So, I mean, you don't get a point for coming, but it's, even though the lectures are recorded, I think you will gain a lot by being there and being able to ask questions. I do want you all to ask questions at any time and just simply turn on your audio and interrupt me. You can put your hand up, you know, the little electronic hand. I'm not sure if I will necessarily notice that because I'm not real good at multitasking. And so I could miss your question. It would not be my intention to do so. So if I'm not responding to the little electronic hand, by all means, interrupt me. The sooner the better. Chances are, if you have a question, somebody else does too, and probably more than one somebody else. It's probably quite a few people who would have a question. So, and then the discussions will be critical. They're really going to be how you learn to use the information. And a lot of the test questions will be using the information type of questions. In other words, problem solving, not just giving information back rotely that you've memorized. But there are questions on that too, a lot. You can't solve problems if you don't have the information up here. So you're going to be learning some things, you're going to be memorizing some things like you did in 344, and I'm going to be testing you on those things. But then the next step is to use that information to be able to solve problems. And I'll give some examples as when we get into the slides of the kinds of problems that you'll be addressing. Okay, so we will do in the classes also, we'll do those 4 hours of observation. You know, you've been doing observations in a number of your classes. I'm not sure if it's all of them, but quite a few of them, in small numbers, because as you probably know, in order to start a clinical practicum, once you're in a graduate school, you need to have already acquired 25 observation hours. And ASHA calls them guided observation. It used to be, we just said, you know, go out, go to a hospital and ask somebody if you could observe them and write a little report and send it to us. You get your hour. ASHA wants it more supervised than that. So we'll watch them together, basically. We'll watch them together and I'll have you provide input, probably using the discussion forum. That particular thing is not graded, but if you're not there and you don't you don't participate in the written discussion, you won't get the hour. It won't affect your grade, but basically you'd have to find some other way to get those hours, because the program has put it all together. So if you take 242 and get several hours, however many it is, et cetera, it all adds up to 25. And so you need those 4 hours. Any questions? Just stop me now. Do you have questions on observation or attendance? Okay, grading policy. We will have almost weekly, they're not every single week, but there are 10 quizzes across the semester. And they are worth, as a total, 15% of your total grade. And so I guess that would make each one worth about a 1.5%. And the way they're going to work is that you'll take 10 and the lowest 3 scores will be disregarded. So it will be 7 of your top 7 scores will make up 15% of your total grade, if that makes sense. And then the rest comes from 2 midterms and 1 final exam. And the midterms, they're all those quizzes and midterms, at least as I'm planning it at this point, will be taken on your own time outside of class in a designated window. And they all have a time frame involved. If you, for some reason now, since you can take a quiz for almost an entire week, probably you're not going to miss any, but if you did miss one, that would just become one of your 3 lowest scores and it would be discarded. If they were in person, obviously you could be sick and miss one, but that we still did it the same way, basically. Just if you miss one for any reason, it's going to be with one of your 3 lowest and it will be discarded.
Do the quizzes have a time frame as well?
Yes, they do, 10 minutes. There'll be 10 questions, 10 minutes. And they are easily done in 10 minutes. Easily done in 10 minutes if you know the material. If you don't know the material, they probably can't be done in 10 minutes.
How many questions per quiz?
Per quiz, 10.
10, okay.
Yeah, and then midterms will probably be around 50 and have about 50 minutes or an hour. And the final exam will be a little bigger than that. And what was I going to say about cumulative? Oh yeah, the quizzes. The quizzes will not be cumulative. I mean, it will be exactly on what we just covered that week, the week before. So like you're going to have a quiz by next, actually next Tuesday night at 11:59 p.m. I made them do the night before so that I would have a chance to look at them. Sometimes the score is unduly low, I guess because it's a harder quiz or I didn't teach the material as well as I thought I did, whatever it was. But I know where the quiz score should come in. And if it doesn't come in there, I give an adjustment to everybody and add a point or whatever works out to bring it in where it should be. So I need a little time to do that. That's why I'm saying. So the quiz will be open to you. Actually, next week's, this quiz, the quiz number 1, will open tonight at 7 p.m. I doubt if you'll want to take it at 7 p.m., but you could. And it will close next Tuesday night at 11:59 p.m. As soon as you open it, you have 10 minutes to finish it, and then that's it. And then we will go over those quizzes it'll be one of the things we start with next week is to go over the quiz. Let's see. Okay, so now it's going to be exactly what I cover. Like, for example, we're going to go through neuronal anatomy and physiology, the anatomy and physiology of the neuron tonight. But let's say I get behind and I don't cover it. It won't be on the quiz then, because I didn't cover it. It's only going to be what we covered the week before, and right now this is the week. Now I had said they're not cumulative, that it's going to cover what we did the week before. However, they are cumulative in this sense. As we get into more and more problem solving, those problems will be on the quiz. Some of them, quiz problems, and problems typically take under some previous knowledge to be able to solve. So you all took 344. You know, if we had just studied the origin and insertion of the biceps muscle this week, I might ask you that. That's just straight out knowledge. It has nothing, it's not clinical problem solving. But then I might ask, some kind of something about the biceps, but takes knowledge about the skeleton, which you learned before. Does that make sense, what I'm trying to say? So they're not intended to be cumulative on the facts, but in terms of integrating new knowledge into your base and being able to use it for problem solving, it would be cumulative. Hope that made sense. And same thing for the midterms. The midterms will be a combination of just plain old facts, and it's going to be pretty much new facts. I'm not just going to, review something from tonight that's simple factual information on midterm number 2. I'm going to put that on midterm number 1. But then when I give you a problem to solve in midterm number 2, it may require information that came from a number of different lectures. Okay. Yeah, I think we won't have a problem with makeups, because you have a large window of time to take every exam except for the final exam. The final will be during the class, and that's just that if you were sick for that, you would need to have a healthcare provider's note, and then we would make accommodations, of course. Okay, scroll down a little bit more for us. Okay, so here we just go through the topic, and you can see it's from the textbook, really. I mean, what I put under lecture topic or activity are the names taken from the chapters of the textbook, and the chapters are shown there, and then I'm showing what quiz or exam corresponds to that. So today we're going to go over an introduction to the place, scope, and importance of neurology and communication sciences and disorders. And we're going to overview the course structure and requirements, which is, not my own stuff, not the, we're doing it now, basically. And then neuronal structure and function. Those are materials from chapters 1 and 2. And then the quiz will open up tonight, and it will at 7, and it will be available for you to take anytime up until next Tuesday, 11:59. So that's how the schedule works out. And then if we go to Canvas, can you take us back to Canvas, Isabel? Since I apparently am blocked from it. If you go through Canvas, you can see it kind of goes week by week and corresponds to the syllabus. So here's module. These are my, if you go up just one more big module. So here are my links that don't seem to work for me anyway, properly. And here's our syllabus, which did work. Thank you. Thanks to Isabel. And then I do say here, and I notified you in email that I would really like you to open your video so that it gives me more feedback, and I just think the outcome will be better for everybody. If there's some reason why you cannot do that, let me know. Okay, then we go through week by week, and I do have 2 weeks of materials all prepared. And these are the readings to do before the lecture. Hopefully you read chapter 1 and 4. And then the lecture slides for chapter 1 and for chapter 4. And then I just posted the next 4 little things, which are links to YouTube videos, very short ones that I thought were really, really nice summaries. After we go through our little lecture on neuronal function, you may want to watch those. You probably will. They're helpful, and it basically gives you the information I'm going to give you in a very brief and concise way with nice illustrations and somebody else's words. And so you'll be able to generalize the information better. And then there's the quiz. So you'll go through everything and then open that up. Right now it won't open up, but I think at 7 o'clock it will. I've opened it a number of times and it worked for me. So hopefully it does. If it doesn't, I know you'll let me know. And then Isabel, when you go down to module 2, again, I just follow the same pattern. I give you the reading for the new material for this coming week. That would be to read chapter 2, and then there's a lecture, and then there's the video that is recorded. And there are 2 of them actually, because I just divided it into 2. You can take them any way you want to, but I found for myself, especially with no feedback, just me talking to myself, to go on and on and on was just unbearable. So I hope it's not unbearable for you right now, but I divided it into 2 mostly for myself, because you can do it any way you want to on your own time. And then there comes another quiz number 2, and so the time frame will be the same. Then I'm almost done with the next modules. Actually, it's going to be a set of 3 modules, because chapter 3, which is the ones coming next, is a really long chapter, really involved, has a lot of information in it. And so it's going to take us 3 weeks. I've got the slides all done, and I'm just recording the lectures. I'm going to do either 2 or 3 lectures for that. Again, just dividing chapter 3 into smaller components. And then there will be a quiz. Actually, more than 1 quiz. I think there are 2 or 3. It shows on the syllabus, but there are either 2 or 3 quizzes as we progress through the material. So again, almost every week there's a quiz. Chapter 3 takes us 3 weeks, but there would still be quizzes on what we covered the week before. All right, that's the organization of the course. I know, we have these things over on the left-hand side, announcements, assignments. There's different ways of organizing those, and some professors I know you might find something that says quizzes, and you get to your quizzes by going there. Pretty much everything that you have to do is in these modules. So the way you're going to get to a quiz is not go to the left-hand column and click on quizzes, because it's not even there. You're going to go to the module that you just finished and click on quizzes, and there you go. You're ready to go. Yep. Isabel, thank you so much for all the good work there. You illustrated everything perfectly. All right, so let's see. I think I have gone through everything I wanted to do. I want to invite any questions you might have just about the course or the organization of the course at this point before we launch into.
I have a question for you. Is it going to be proctorial?
Proctorial? Do you mean will it be proctored?
Yeah.
Only the final exam.
Oh, okay. So we're not going to use proctorial for any of the quizzes or any. Okay.
Nope. You're just going to do them on the honor roll. Frankly, I think if you consulted with somebody, it would slow you down so badly, it would really mess you up. So I'm expecting that for a variety of reasons, not the least of which is ethics, you'll work independently, and it'll work much better for you. And then the answers are all randomized and everything. So just to even figure that out would be a burdensome and slow you down. So yeah.
I have a question.
Is it Jasmine? Was that Jasmine?
No, but I have a question too, but I'll ask it after.
Okay, who's next?
My name's Heidi.
Heidi, I don't see your picture.
Oh, really? I have my
Oh,
video.
now I do. Okay. Usually when you say something, your picture comes on right away.
Yeah. So my question is just for module 2. You said you posted the lecture videos. are we still going to have class next week, or should we just watch the videos?
Oh, no, definitely going to have class, because what we're going to do is we're going to start with going over the quiz, number one, answering any questions you have about the material, including redoing part of the lecture or going through some slides, whatever it is, what your questions are, address your questions. And then when you run out of stuff, I've got stuff, and my stuff is going to be problem solving. You'll start problem solving right away with the information that you have been given so far. So of course, obviously after one week, you can't solve a lot of problems, but you can solve some.
Thank you.
Okay.
I had a
Oh, and then
question
Jasmine had
similar.
a question. Jasmine.
Yeah, I had a question similar to that. So you said that if we don't touch something in class, then that will not be part of the quiz. But since you're pre-recording the lectures, then should we assume that the pre-recording should cover it, or should we wait until, because I mean, you're asking for us to watch the lectures before class. So if we don't do like an activity, or we don't touch on the lectures, then I'm a little confused about that.
Oh, okay. Well, I think you're asking. I interpreted the question initially to be what would be covered on the quiz. If it's not in the lecture, let me just answer that. And if I didn't get your question, Jasmine, let me know. If it's not on the lecture, whether it's a pre-recorded lecture or a live lecture, if it's not in the lecture, it's not going to be on the quiz. Now, that being said, a lot of times the slides that go with the lecture are just points, like a word, whatever. And then I talk about that. What I talked about is going to be on the quiz. So there's, I guess, yeah, it's basically what's covered in the lecture. I'm not going to, in fact, I don't think you will find anything on a quiz that wasn't covered in the lecture. I'm not looking for things for, unusual stuff from the textbook that I didn't cover and purposely putting it on a quiz. That's not my intention. Believe me, I'm covering a lot. There's plenty in the lectures for you to learn. Jasmine,
All right,
did I get every part of your question there? It seems like
Yeah, it was answered. Mhm.
Okay. Any Anika, did you have something you were going to ask?
It was the same question earlier about Proctorio. So no, I got answered.
Okay, all right. Any other questions?
I just have to say that I love that you're pre-recording the lectures, because we did that for 242, and I mean, it just went smoothly. It just didn't seem like a lot of information at once.
Okay.
So I love that.
Oh, good. Well,
Well,
I appreciate that feedback. And, when I started thinking about the disadvantages to being virtual and everything, and, how to really do this best, I thought, I'm going to feel kind of rushed just getting through that lecture and creating a little bit of time at the end for discussion and problem solving, but I don't think it's enough time. So I kind of think that my biggest reason for it, and I know students appreciate it for a variety of different reasons, so you can listen to the lecture again, etc. But my main reason is that I really think it will result in better learning in the sense that you'll have the far more opportunity to really integrate the material into your working knowledge and be able to use it both in class and in your career, of course, too. So good. Glad you like that. All right. Any other questions? Sometimes I forget to take a break. Excuse me. I actually put my alarm on right now, so it's going to ring at 5 o'clock, and we're going to take a 10-minute break. Even though we kind of had a rocky start and maybe could go longer, but we'll take a break then. But sometimes I might forget, and you can just interrupt me and say, could we have a break now? And I'm not sure whether, ordinarily I would just take one 10-minute break at the halfway point. This seems kind of intense to me. I don't know if it does to you or not, especially with my technology problems. It wears me out. So I thought I might need a break at the hour. So we'll do that. We'll do that today and then see how it goes. Okay, anything else? Okay, you can stop sharing your
Your question.
screen, Isabel, and thank you so much for doing that. Did I hear another question?
Yes, I had a question.
Okay, is it Ruby?
Yes.
Okay,
I was wondering what type of questions should we expect on the midterms?
oh, okay, they're gonna be just like the quiz questions.
So are there going to be any short answer?
No, it's all multiple choice.
Okay, thank you.
Oh, sure, okay. Yep. Anything else?
Are the
Okay.
quizzes, sorry, are they based on the reading and the lectures, both of them?
Oh, okay, they're gonna be based on the lectures, but I'll tell you where the reading's gonna really help, because I don't know how to express this well, but I think you'll know what I mean. Sometimes when you're learning new things, and I would say almost always when you're learning new things, especially if they're kind of complex, what you're learning is literally the words that I say, you know? To the point where you hear somebody else say the same darn thing, but it use different words, and you don't get it. See, it doesn't click because you haven't generalized the knowledge enough. So having the opportunity to hear the way I say it and then read it and see pictures is going to really help you to learn the concepts. They become not just my words and the words I chose to put on those slides, but they become the true knowledge with all of the nuances that knowledge has. You know, the knowledge like this has, well, it has many representations in your brain. It does have auditory representations. It certainly has anatomy, certainly has visual representations. Literally, by the time you're done with the course, you should have a image built into your brain of the brain. So just like you have that kind of an image for, well, we all live in Southern California, so you all know how to get from here to there. And if the road is blocked, you know, 2 different ways to get there, you know, because you have the whole thing built in. And when you first started learning streets, literally somebody said, you know, go down Washington Boulevard and turn right on Schaefer and blah, blah, blah. And that's the way you learned that route. But at some point, you did that so many times with so many different streets and so many that you constructed a map in your brain. That's what we're trying to do with neurology. So you can't get that map if you just listen to my words. That's basically what I'm trying to say. You're only going to get it if you hear it in a number of different ways. You can try to figure out why I'm saying it differently from how you're reading it, etc. And sometimes we're going to discuss that. You'll have questions about it. But out of that, you'll come with a true knowledge of neurology, a usable, not just to take a test. We will test you. I guess it's kind of the only way we know how to do it, but ultimately you want to be able to use that knowledge. And I'll give you some examples tonight of how we do as SLPs. Any other questions? All right, so let's let me find my slides here. Okay. Okay. All right, and we are still recording. So this is all about chapter 1, at least my interpretation of it. And my first question is how does an SLP, and I need to move something on my screen. Something's getting in my way here. How does an SLP utilize knowledge of neurology? Well, we're going to help you to learn how to understand how the neurological system participates in everything that's important to us as SLPs. And that is how speech is carried out, how language is processed, how cognition works neurologically, and how swallowing works neurologically. By the way, do you guys cover swallowing in 344, maybe it would be, you know?
Somewhat, yeah.
Somewhat, okay. But probably not, you didn't do anything about the neurology of swallowing.
No.
Okay, so by the time you finish, you'll understand why strokes, for example, in a certain very small part of the brain stem, the lowest part of the brain, cause one kind of a swallowing problem, and strokes up here in the cerebral hemispheres cause a different type. So that will all make sense to you. We want you to understand the basis for the neurogenic disorders of these functions. How does a normal work? How does a pathology work? Neurogenic means something that is caused by a neurological disorder. So these would be disorders of speech, language, cognition, or swallowing caused by neurological problems. You can have trouble with speech because of an injury to the mouth, for example, but that's not what we're talking about. Or head and neck cancer will cause trouble with speech, as you know. But that's not what we're talking about in this course, just the neurogenic disorders. You'll know how to diagnose the disorders of these functions to some degree. Now, we're going to certainly look at the differences, the major pattern differences, and you'll get into testing and diagnosis to some degree, but you'll learn a lot more later. Also determine the prognosis for the neurogenic disorders. Do you guys know what prognosis means? It's the likelihood of getting better or staying the same, or sometimes prognosis is not a good prognosis. There's a likelihood of getting worse. Either which way, that's referred to as the prognosis. And as SLPs, we want to be able to know what the prognosis is for any patient that we see, because if we don't, we can't plan appropriately. For example, some neurogenic speech and language disorders start bad and get better, and most of those people warrant having rehab. Some neurogenic disorders start mild and get worse, and it can even get worse very, very rapidly, to the extent where it might make sense to do accommodation of various kinds, but not rehab per se for somebody who's getting worse very rapidly because of their prognosis, which goes back to the neurology. So in order to be able to determine a prognosis, one thing you do is you do detailed testing of the speech, language, cognition, or swallowing, whatever it is you're addressing. But you could have two different patients who have precisely the same pattern of test results, and they have completely different prognoses. So we have to understand the prognosis, and the only way you can understand the prognosis is if you understand the disease process. And the only way you can understand the disease process is if you understand neurology to begin with. So that is about prognosis. And then from the prognosis, I kind of alluded to this, comes a treatment plan. For some people, again, they could be two people who have exactly the same pattern of speech, language, cognition, and or swallowing test results, but they have very different prognoses, and they will have a very different treatment plan too. All right. There, okay, so on to the next one. We're going to talk about the central and the peripheral nervous systems. I'm not sure if the terms mean anything to you, but I think they might. Central nervous system, we're going to look in detail at, a little bit of detail tonight. The brain, basically the brain and the spinal cord, and then the peripheral nervous system is all the nerves that run every place in the body. And these are responsible for controlling swallowing, motor speech production, language processing, cognition, which includes those various things. And I have swallowing on there, good. Okay, our knowledge of neurology helps us as SLPs to understand how diseases and injuries involving the CNS and PNS result in particular patterns of impairments in those functions. In those functions, but now the second point, sometimes you kind of think you understand the speech and language problem or the cognitive problem or the swallowing problem from an SLP perspective, that you accomplished a diagnosis, but it doesn't fit with the rest of the neurological deficits that are present. For example, when I say a neurologic deficit, what is one? Well, it might be a weakness on one side of the body. It might be a drooping on one side of the face. It might be a tongue that deviates to one side when the person protrudes it. All those things add up to a set of neurological signs and symptoms, and they should go along and be compatible with the speech and language diagnosis. And so as SLPs, we're looking for that, because if they don't match, there's something wrong. Could be our diagnosis. It could be that there's something else going on with the patient, in addition to what is already known. So we want to be able to recognize those larger patterns and to see if they fit together or do not. And in order to be able to do that, you have to understand the neurology, and not just the neurology for speech, language, swallowing, and cognition, but for all the other major functions, the movement of the body, the paralyses these person may have, the loss of sensation, etc. And Angela, were you going to ask something?
No, sorry.
Okay, that's all right. So again, we need to know those things in order to be able to determine a prognosis and plan appropriate treatment. This is, again, I sort of said this, but I will say it in a slightly different way. The disorders that can be caused by neurologic disease or injury include dysphagia, this disorder of swallowing. By the way, do you hear the way I say it with a rather prominent G? Did you know that there's a word with an S instead of a G there, dysphagia? Do you guys know that? Have you ever heard of it? You all know what aphasia is. Yeah, okay. Dysphagia is actually a more accurate label for that disorder, because most people don't lose their language completely, 100%, which is what aphasia means. Aphasia technically means complete loss of language. Hardly anybody gets a stroke and loses their language completely. They really have dysphagia. So that there's possible confusion, like they sound almost the same. So I pronounce it with a very hard G, dysphagia. So if you hear me saying that, that's what I'm referring to. And dysarthria is a motor speech problem involving weakness or incoordination of the muscles. And it's rather consistent. In other words, somebody, when they have dysarthria, anytime they speak, it sounds kind of the same way. Apraxia of speech is also a motor speech disorder, but there's an inconsistency in apraxia of speech. And we will study, of course, all three of these. Have you heard the term apraxia of speech before, or sometimes people call it? Okay, so you're somewhat familiar, probably from 242, I would guess. Aphasia, now I just gave you this little lecture about dysphagia, and then I wrote aphasia, simply because that is by far the most common terminology. It's not quite really an accurate label, but it's our label and everybody recognizes it. So there it is, the language problem. A minor hemisphere syndrome, did you study that at all in 242? Minor hemisphere syndrome is the problem with cognition and communication that results when there is a damage to the hemisphere, the brain hemisphere that is non-dominant. So in other words, if you had a stroke on the dominant side of the brain, chances are you would have an aphasia. If you had a stroke on the non-dominant side of the brain, you would have a minor hemisphere syndrome, and we will study that. Those people can speak, but oftentimes one thing that is very disordered in them is their ability to tell a narrative, to tell a, like a story. They get the sequencing all mixed up and they're incomplete. So we'll study that. And then finally, cognitive communication disorders would include dementias, as in Alzheimer's disease, and traumatic brain injury. And so we'll study that, and you'll understand, you should be able to draw a link between the location in the neurological system where the damage is, and the pattern of the impairment that the patient has, and the diagnosis that they have. Okay, now we're going to just give a definition. I sort of gave a definition already, but here a little more detailed, and for you to be able to read it too. Dysphagia is a disorder involving swallowing, can be caused by anatomical impairments of the upper aerodigestive tract. Now that would be an injury, or very often, probably the most common one is cancer. The presence of a cancer or tumor itself can affect swallowing. Or sometimes, oftentimes what happens is the person had some degree, or maybe even no degree, of swallowing impairment from a cancer or a tumor until the surgery. And after the surgery, they had an impairment of swallowing. So sometimes the treatment will cause the problem too. But the point I'm trying to make is that's an anatomical problem. It's not a neurogenic problem. But of course, dysphagia can also be caused by neurologic disease or injury, and that is the most common one. And it can also be caused by deconditioning. Deconditioning is what happens, this is kind of a new idea. If you just lie in bed, now none of us would do this, but if you lie in bed and literally don't turn over, but somebody comes in and turns you over for a couple of weeks, as it would happen if you're really, really, really sick and in intensive care or something, you can actually develop a dysphagia simply because you haven't been using anything. You're just lying there. And we didn't used to know that. We always said it was either an anatomical problem from a cancer, etc., with the upper aerodigestive tract, the part you do the swallowing with, or neurologic disease. Now we know it can be from deconditioning too. We know a lot of other things as well, but that's suffice it to say that's what we have right now. Dysarthria is a disorder of speech production caused by neurologic disease or injury involving respiration, phonation, resonance, articulation, and or prosody. So it could be any one of those things, and I think you probably know that from 242. So hopefully kind of old information. Apraxia of speech is a disorder of motor speech production caused by focal brain injury. Focal means in a specific location, not just somewhere, but in a very specific location. And the problem is with the smooth production of speech, especially when speech is produced more or less, more intentionally as opposed to reflexively or automatically. Have you heard about people who have apraxia of speech being able to swear? That's the difference between them and a dysarthria. Swearing tends to be reflexive, just automatic. If you bang your thumb with a hammer, you might swear. And by the way, even people who their loved ones said they never swore often will swear after this because it just sort of comes out. And they do it reflexively. And when they do it, they sound fine. So if you ask them to take that little swear phrase or whatever it is and repeat it again, now you have taken a reflexive response, automatic response, and made it into what I'm referring to as an intentional response. That's where the problem is with apraxia of speech, the intentionality. With the dysarthric, it can be reflexive, it can be intentional. It sounds the same, it's dysarthric. So there's a consistency there. With apraxia of speech, there's an inconsistency. And we'll study that quite a bit. In fact, I'm sure we'll have one of those as our cases for our observational experiences.
So would that be like, I don't know, I'm thinking like Tourette's? When you
No, it's different. Actually, Tourette's is a dysarthria. It's a hyperkinetic dysarthria. Yeah, and so I don't know if I have an example of Tourette's, but they're kind of easy to find. But no, it would not be an example of Tourette's. Tourette's would be, if there is a speech problem, it's a dysarthric speech problem. Yeah, thank you for asking that. Aphasia is a disorder of language processing caused also by focal brain injury, involving, and again, remember, focal means in a specific location, not just anywhere, or not diffuse. Diffuse injury is sort of all over, you know. It may not be very, very severe. It may not even show up on a CT scan, as in a concussion. The concussion is a diffuse injury. If you do a CT scan on the person who's still has the confusion, you won't see anything. A CT scan is a computerized set of images of the brain, and you can see very precisely, but you wouldn't see any problem with that person because they have a diffuse injury. And with aphasia, it's a focal injury in a very specific language area, and we'll study that. And it involves language spoken or written or heard or read. In other words, there's no way to get in or out of the language system without manifesting the language impairment. Different from a speech impairment. So somebody with a speech impairment, like the dysarthria or an apraxia of speech, they can understand what they hear, they can understand what they read, but they have that, you know, whatever the pattern is, the particular output problem. Somebody with aphasia, input and output is impaired. But if you go completely around language, they process quite well. For example, if you ask a severe aphasic to touch their nose, they may not be able to do it. They just, you could speak, might as well speak German to them. But on the other hand, if you say, okay, now do what I'm doing, and you get them to get the idea, then you could do command after command after command, because now they're demonstrating that they can do the activity, they can do the movement, they can follow the command, just not the spoken command or the written command for that matter, because we bypass language in the example that I gave you. That clearly demonstrating that that person has aphasia and not a dementia or an Alzheimer's disease or something else that might prevent them from following a simple command.
Professor, I have a question about the apraxia of speech.
Isabel, say again.
I have a question about the
Oh, yes.
apraxia. So would you say it's common for those with apraxia of speech to demonstrate like characteristics that are like out of character for them? Or is the inconsistency just like regards to their speech or like things they say?
Oh, okay, gotcha. I think I understand what you're saying, what you're asking, Isabel. Yeah, the inconsistency is in the speech. It would not, usually would not involve inconsistency in other kinds of behaviors. Is that, you know, like maybe doing unsafe things around the house or something like that?
Oh yeah, I was just interested in how like maybe the swearing thing and then how that played into it. So I was
Oh,
just,
gotcha. Yeah. No, the only reason that why there's that difference, and it's not even only swearing. If you go to somebody who has a severe apraxia, who maybe does produce a word once in a while, you know, and you just say, hi, they might just say hi back, just like that. And if you said, oh, you just, whatever it is, you just do something that's real automatic, flows real easy. And once they do it, they say, oh, great. Okay, now I want you to say hi. Can't do it because we've taken what was produced reflexively or automatically, and we have made it into an intentional thing.
oh, I see.
And then you see it. So no, it's not that they are, you know, don't know what they're doing or, you know, anything like that. No, they definitely know what they're doing. If they just have a pure apraxia of speech. Okay, well, I had, my alarm did go off. And so why don't we take a 10-minute break and we'll come back and resume where we are. And I think that I'm going to just let the should I just let the recording go? I don't want to have trouble with it. I'm going to stop sharing the screen and then go down here, and I think I can just pause it. Okay, now we're recording. All right, And let me go back and share the screen again, and then I'll answer your question if I can. Okay. Who has a question?
Oh, it was me, Annika.
Annika, yeah.
So I'm not sure if somebody already asked this. So what is the relation of apraxia of speech to childhood apraxia of speech? Like, is there a slight difference in that? Because I know we learned specifically about childhood.
Right. Yeah, there's well, they are different, because what happens with it, what happens with an adult who has apraxia of speech is that they have established the patterns for articulation, but they just can't get to the patterns smoothly. Sometimes they can, sometimes they can't. With a child who has apraxia of speech, they're affected differently because they never had the patterns to begin with. And so a lot of times the way they'll make that diagnosis is not so much listening to the speech, but watching their articulate, I don't mean to say articulation, their non-speech praxis. I'm using this word praxis, Praxis, praxis. That's coordinated, purposeful movement. And so if you work with the articulators, but not speech, just like show them, stick out your tongue, do this, and just show them the different oral movements, they will manifest an oral apraxia. In other words, they can stick out their tongue if they're not really trying to do it, but when you make it a purposeful activity, then they have trouble. And that's how they'll end up making that diagnosis. They say, well, they're having trouble with intentional movement of the articulators for non-speech. Obviously, it must be affecting their speech, and what we're hearing is childhood apraxia, if that makes sense.
Yeah, it does. Thank you.
All right.
Just to be clear, Professor, with the apraxia of speech, it's non-intentional, right? So if it's intentional, it's dysarthria, is that right?
Oh, no, let me clarify that, or say it in a different way. That the thing with apraxia of speech is there's a difference in the quality of their speech between reflexive and intentional. Are you okay with that so far, just that statement? Okay, but if you go to dysarthria, there's not a difference between those two. It's the same. And it's, let me go back to the myasthenia gravis, which causes a dysarthria. What happens is that the nerves cannot communicate to the muscles to contract. Now they can do it a little bit, but they can't contract very well. So they're weak. They're really, really weak. They may not be able to walk. They may not be able to, you can hear them, but the speech is very indistinct, very quiet and indistinct. And it would be the same from one moment to the next. It's consistent. Whereas with the apraxic, sometimes they can say that word and sometimes they can't, whatever it is. And the more you try to get them to do it on purpose, volitionally, I'm calling it, or intentionally, the worse it is. Okay, does that do it?
Yeah, that's
okay, Georgina. Renat, is it Renate or Renat?
Actually, my name is Renate de Ruyter. So
okay,
I'm
Renate. Okay.
The rebirth of the Dutch cowboy.
Okay, thank you. Sometimes if I get your names wrong, let me know. But I hopefully recognize that I may not be right. Okay, now that we just kind of give an overview of the kind of SLP problems we'll be concerned with, and understanding also that we're trying to fit them in with other patterns of neurologic deficits, like weaknesses of different parts of the body, or losses of sensation, or losses of part of your visual field, whatever it is. We're just going to go look a little bit at the history of neurology. And so we're looking at historical roots of neurology, and we're starting with this theory of localization of function. It's a localizationist perspective on higher cortical functions. Now, we're not talking about strength or sensation, basic neurologic functions like that. We're talking about higher cortical functions, meaning language, memories, thinking, things like that. Those are the higher cortical functions. And there's the oldest theory about how our higher cortical functions are carried out is called a localizationist perspective. And it was started by and elaborated on by two neurologists. One is a French neurologist, Paul Broca, and the other is a German neurologist, Karl Wernicke. And the way they came up with this theory, localizationist theory of higher cortical functions, was by observing patterns of neurologic deficits in people who had lesions in certain parts of their cerebral cortex. That was, 1861 was before we had CT scans or anything like that. So how do you think they would study where the lesion was and link it to the behavioral deficits? How do you think they did that?
Autopsy.
That's how they did it. Autopsy. You had to wait. You had to make all your notes, all the neurologic observations about the deficits that were there, and then wait for the person to die, and then do the autopsy and see where the lesion was. And by doing that, case after case after case, they came up with these theories that certain parts of the cerebrum had specialized functions that were associated with them. And Paul Broca discovered that actually with apraxia speech. We also oftentimes call it Broca's aphasia. And the area of the brain is called Broca's area. And that is the area that is responsible for our articulated speech. And then a few years later, Karl Wernicke made a related set of observations about people who had lesions a little bit further back, usually on the same side of the brain, and usually almost always it was the left side of the brain, the language dominant side. And that's how they discovered that. Even when you think about language dominance, that's kind of a localization of function too, localizing language to the left. But even more than that, Broca localized motor speech production to the front part of the left side, and Karl Wernicke associated language processing in general with the posterior part of the left side. And what came to be called, among other things, sensory aphasia. So we had a motor aphasia and a sensory aphasia now. And those patients helped them elaborate upon this theory of localization of function. And this is just a picture of that. We're seeing it. Why don't we look at the right side first, because it's a simpler picture. The dark blue area here is labeled Broca's area, and then darker blue, not as dark, but darker blue in the posterior area is labeled as the Wernicke's area. And so now you know where they are. And then over here, and we'll study these numbers in more detail later. I think it's actually in chapter 2. But for right now, first of all, just want to point out that there are all these numbers. Of course, if you look at a real brain, the numbers aren't there. But these numbers are associated with specialized areas of localized function. So Broca's area, here they've also written it in, is numbers 44 and 45. And those numbers have something they're called Brodmann's areas. Brodmann's areas. And maybe I talk about this next week in chapter 2, but some neurologist named Brodmann developed this conceptualization in which they just took the work of Broca and Wernicke's and elaborated upon it more and more and more, and found all these different zones of the cortex that did different things. And so look, we'll go through those different things that they do. So you come to associate motor speech production here with Brodmann's area 44 and 45, and then Wernicke's back here, the posterior part of Brodmann's area 22. 22 is a little bit long, and it's just the posterior area. So those are the language zones of the brain. And then there's a set of neurons, a bundle of neurons that connect the posterior language zone, Wernicke's area, with the anterior language zone, Broca's area, and that is known as the arcuate fasciculus. And we'll look in more detail at that. That just gives you kind of an introduction to where they are. and different ways that we label surface areas of the cerebral cortex. Okay, then there's another kind of view of cortical functioning that came about early in the 20th century. That I just want you to have an awareness of it, basically. That was a contrasting view that all parts of the cerebral cortex were capable of mediating all higher cortical activities, and that there wasn't quite as much specialization as you might think. Carl Lashley was, I believe, a psychologist. I don't think he was a neurologist who developed this law of equal potentiality, which simply said that every part of the cerebral cortex had the capability of doing everything. And there is some evidence for that. For example, if you look at the well, we know that language is in the left hemisphere of most people, but there's a condition in which a baby can be born without a left hemisphere. They have a right hemisphere, but not a left hemisphere. So now you look at language development in those babies, and they develop language quite well. What's that say? It sort of says that that right hemisphere has the potential to acquire language, and more so than would be thought of if you just think of a localizationist approach, where every little area has its special thing that it does, and it's sort of set in stone. So that became more and more, and there were more kinds of observations in support of that theory. And the big names was Carl Lashley. Hewlings-Jackson was a neurologist. And then this last one, I found this very interesting. I discovered it when I was in my master's program. Do you know who Sigmund Freud is? Have you heard the name? What do you associate with him?
The ego.
What was it, Renate? Or
Psychologist.
A psychologist, psychotherapy.
Yes, well, actually he's a psychiatrist, and he developed the psychoanalytic theory, and did, psychoanalyze people, and discovered, we've all got a bunch of repressed memories from our infancy and stuff like that. So, and he got into the unconscious and brought things up and healed people that way. At least that was the idea. So he's a psychiatrist. That's an MD who has specialized in psychiatry or psychology. But he was actually, I think he sort of like started psychiatry because his real training was that of a neurologist. And his very first book was called On Aphasia. It was only 80 pages, and you can find it. It's in our library. It's just a fascinating and extremely readable book. You can read it in just several hours. And he just goes through cases and develops this kind of theory that's sort of a cross between a holistic view and a localizationist view. And he made all of his arguments based upon case analysis. Here was the lesion, and here's what we saw, and he argued for both holistic functioning and localizationist functioning. So if you ever have an extra few hours to kill, well, I shouldn't say to kill, because it's very useful, actually. It's just a very fascinating book that he wrote that, I think, in 1880. And as I read it, I just was, I was reading about Broca and about Wernicke and about Lashley and about this argument. And then you just read this guy who actually is famous for something else, who somehow brilliantly put all these pieces together with case analyses and made the brain make sense. So we're not going into much depth on that, but that's, now at least you know what localizationist theory is and holistic theory. And then we get to more recent times. There's a name that you will hear if you're in aphasiology at all, Norman Geschwind, who is a Harvard neurologist. He was, I don't think he's alive any longer. And he popularized a localizationist approach to aphasia diagnostics. There's an exam that is linked to him. He didn't actually develop it, but it came out of the same group of people called the Boston Diagnostic Aphasia Exam. And we use it a lot, and it gives us a very standardized way of assigning a type of aphasia to an individual patient. So and that is kind of a localizationist view. Like if you have it, if it's up in Broca's area, you'll have Broca's aphasia. If it's in the posterior part of Brodmann's area 22, be it Wernicke's aphasia, and there are, well, if it's the arcuate fasciculus, this is kind of interesting. If it's in the arcuate fasciculus, those people can speak volitionally and they can understand, but they can't imitate because they can't get the information from the posterior language zone to the anterior language zone to accomplish the imitation of speech. And they have what is called a transcortical motor aphasia. So he's got all these different types. It's like 7 of them, I think, including a global aphasia where everything's gone and it's the whole thing, everything between the anterior speech zone and the posterior speech zone. So we'll get into that a little bit more when we get to aphasia, like how do modern SLPs conceptualize language processing in the brain, and is it more of a localizationist approach or a holistic approach? Okay, I think we're almost there. Okay. This is now a complete change in directions, but the reason I put it in here is it's in chapter 1. And it is kind of information that we need so we can communicate together. And this has to do with directions. And it's a little bit confusing, but I'm going to tend to always use the same terms. So let me go through them all, and I used them all, even though I don't necessarily use all of them in reference to the brain. But anterior, I think I do. Anterior is front, and that's illustrated here. And then posterior is back. I don't, so far, not anything new. Isabel, were you asking something or no? Okay, all right. Superior is top, and inferior is bottom. Rostral, I find this confusing. We're going to use rostral and caudal a lot, so I do want to talk about it. They show rostral coming up here and caudal going down there, which is kind of clear, but the way we're always going to use it is to show relationship between two structures. And basically, if one structure is rostral to another, it's more toward the head. If one structure is caudal to another, it's more toward the tail. That does show this. And so it kind of shows it, but I wouldn't have brought it out here and try to equate it to anterior. Ventral is actually toward the abdomen. Dorsal is toward the back. We do use it in reference to the brain. But it's more typically used in reference to the body, which is shown, I think, in the next slide. See, this really works. Now, that's posterior, that's anterior. You get into the brain, it doesn't work quite as well. And then this thing is really confusing to me, rostral and caudal. I would just take that out because this works. There's caudal toward the tail, and rostral they're showing toward the head. And we will use that terminology a lot, rostral and caudal. Posterior and anterior a little bit, and I think that will kind of make sense to you whenever we do. And dorsal and ventral, we'll use that some too. But hopefully the illustrations make some sense, and do read the text. And then whenever I use such a term and you're not, it's not clicking for you, do say something so we can get you oriented. Okay, now we're going to talk about anatomical planes. I'm not sure if you went into anatomical planes in 344 or not. You did. So it's not going to be real new then. They're hypothetical planes used to transect the body so that we can visualize something or we can describe something in some way. And so when you look at anatomical images, like a lot of anatomical specimens are a body literally sliced. You can slice it in one direction to separate front from back and then look at the cut surface. You can slice it down the middle and separate right from left and look at that cut surface. And so those all have names. And I think that I have separate slides here. These are the ones we're going to look at. I think the separate slides show coronal. Coronal is a hypothetical plane that does separate front from back. And these are CT scans. You all know what a CT scan is? It's a computerized imaging technique. And what you see in the CT scan then is a series of planes. If they do a CT scan of the head, which is what we would generally be interested in, a CT scan of the head will show a whole bunch of different pictures, and they look like this. This is a coronal section. And if you keep looking at the slices further and further back, pretty soon you get to a little tiny brain and then the skull, and there is no brain because the technique itself produces these images that is as if slices were being taken through the brain in a coronal direction, and then you can look at them all. So it gives a way to see everything that's in there. Like maybe there's a tumor here deep in the brain that in the images that are more toward the front, it doesn't show it. But then when you get back to where the tumor is located, it shows up. So it's extremely useful. Before CT scan came into being in about 1975, the imaging technique was an X-ray. An X-ray looks at bone, basically. It can see the bone really well, but not much else. And there were some kind of specialized techniques that would let radiologists see a little bit more than that. Basically, it was pretty primitive, and you couldn't see a tumor. There's no way to see a tumor with most X-rays. It wouldn't show up. CT scan, yes. Most tumors will show up on a CT scan. And so this right now, I just want you to understand that the anatomical planes and be able to relate that to CT scans then as well. And A and B here, down here, are CT scans that are done in the coronal plane. And they show here A and B. That's where the cuts would be, more or less in the center of the head here. But a set of CT scans would be the whole head. Now, of course, you can scan any part of the body, but they don't scan the whole body. They scan the part that they're interested in. This is a horizontal, axial, or transverse section. Axial is a very unusual term. I don't think that's very typical, but your textbook had it. Horizontal and transverse would be very common. You can see C and D. It's a horizontal cut plane through the head here, and it looks like this. So that's separating top from bottom, something above from something below. And then the next page shows a sagittal image. And there are two terms here to be aware of. One is a mid-sagittal. That's a sagittal view that separates right from left. And the cut is right down the center. So here is A is a mid-sagittal, also called a median plane, but it's a mid-sagittal view that cuts through something right at the center called the corpus callosum. We'll get to that, but you might have heard of it before, I don't know. And then if the plane is off of center, it's referred to as parasagittal or paramedian. And again, it's separating right from left, but not with the cut right down the middle, but off. Could be all the way over to, practically the ear, or it could be any distance. And again, in a set of CT scans, it would be the whole, generally the whole head. It goes all the way across. It's a number of scans. All right. Now we get to what a quiz question looks like. So for the first one, why don't I let you read it, and just if you think you've got the right answer, speak up, or you can chat it to me.
Is it B?
Oh, it might be. Now let me read the rest. I better read myself. Set you to work, and then I take a relaxed moment here. Well, now A is kind of right, but it's not general enough. So it's one example of localization of function, but that's not all there is to it. So B, the fact that specific behavioral functions appear to be associated with clearly localized sites within the brain, that looks pretty good. Let me look at C. The fact that each organ of the body contributes in its own unique way to the function of the whole, no. The fact that the two hemispheres of the brain are symmetric in their function, no. Okay, yes, it is B, very good. Any questions about that one before I go to the next one? Okay. Lesions in Broca's area cause motor aphasia, sensory aphasia, agnosia, or apraxia. I don't think I haven't said the word agnosia yet.
A.
Right?
Motor aphasia, yeah. Now, I believe your textbook did use motor aphasia, and I'm not sure I called it that when I was lecturing, but you are correct. Sensory aphasia is another name for Wernicke's aphasia. Motor aphasia is another name for Broca's aphasia or apraxia of speech. Agnosia is a perceptual problem caused by cortical lesions. Like you can see it, but it doesn't make sense. That's an agnosia. And apraxia is, now the problem with apraxia, you could say it's D. You could say it's D, but apraxia is a little too general. You can have apraxia of any part of your body. You can have apraxia that, somebody who played the piano has a lesion in a certain part of their brain, can't play the piano anymore, but they can move. They just can't do the coordinated movements of volitionally. If they don't think about it, it'd be better, but if they do, it's worse. So apraxia is almost right, but it's a little too general a term. If you said apraxia of speech, that'd be fine, or motor aphasia. And so it is motor aphasia.
You won't be using expressive or receptive?
You know what? I'm not, I do have my favorite terms, but in general, I can say that my approach is to go ahead and use many terms so that you kind of have familiarity. It's not just, what Kurt chooses to label something out of the several, but to tend to use them all within reason, hopefully. Okay, lesions in Wernicke's area cause what?
B.
B, you're absolutely right. And I think I did use that term, sensory aphasia, didn't I? Okay. And a dysarthria is what?
D.
B, did you say?
No, D.
D,
A
yeah.
neurologic speech disorder.
Yep. A neurologic speech disorder. We could also say a neurogenic speech disorder. It would be the same thing. Neurogenic's a little more grammatic, but neurologic is not wrong. Okay, there might be one more. Oh yeah, structures lying at the base of the brain may be anatomically described as being.
Nodule? C?
Which one?
C?
Say it again.
C?
C, yeah, caudal. Yep, exactly. So I don't think there's another one. That's it. So those are sort of examples of quiz questions. And I think I have them at the end of every lecture. Okay, now we're going to get rid of that one and go to another screen. How you all doing? You staying awake?
Yes.
Okay. All right. Okay, so I have to share another screen. And this will be number 4, chapter 4. It's on neuronal structure and function. And you do see it, right? Okay, so now we're gonna work on how brains work at the cellular level, at the cell level of neurons. And in the nervous system, which includes, of course, the central nervous system and the peripheral nervous system, and includes both, there are neurons and there are glial cells. The neurons are the cells that actually carry the information from one thing to another. And I want to describe or define some of these terms. Cells specialized for receiving and transmitting electrical impulses to and from each other, neuron to neuron, or from sensory receptors, like the rods and the cones in your eye that pick up the light. They connect to a neuron. Okay, and then the neuron carries the information to your brain and you see. Or you know about hair cells yet? Okay, those little hair cells in your inner ear attached to a neuron, and those are sensory receptors. So you have sensory receptors for touch, you have sensory receptors in your joints and your muscles for movement, so you can, you feel when you move and you know where you're moving. We have sensory receptors in our semicircular canals for balance. So I've got touch. Oh, we have sensory receptors in our nose for smell, sensory receptors in our surface, our tongue for taste. I've got vision, audition, vestibular function, touch, movement. We have sensory receptors for pain. And those are all sensory receptors, and they all connect up to a neuron, which carries the information back to the brain. Okay, and then there are effector organs. I think I used the term because your textbook did, and that is fine, it's fine, but what exactly is an effector organ? Well, mostly, especially in our course, we think of an effector organ as a muscle, something that does something. But an effector organ could also be a gland. Glands are innervated by neurons too. So they do something, they secrete something. Okay, so mostly from our perspective as SLPs, we'll be thinking about muscles as the effector organ we would be interested in. Glial cells are not neurons, but they are all throughout the entire nervous system, peripheral nervous system and central, and their job is to maintain homeostasis, balance, and to provide support and protection for neurons. Some of them literally, when a neuron dies, they come in, clean it up, and take it away. And one that's very important, and we'll study just a little bit more than any of the others, would be those glial cells that form myelin, which is the insulation around certain neurons. And what myelin does is allow the impulse that's going to travel down the length of a neuron to go faster. It's like an insulation. And some of our neurons have them, the ones that need to kind of operate fast, like for example, for touch, you need to have touch information come back to you pretty darn fast in order to be able to do all of our activities, really. Like when you think about walking, you need to know exactly when your foot hits the ground, and you do it by touch. And it's really fast transmission back to your neurological system so that you can process that information and not keep pushing your foot down further when it's already there, just as a silly little example. But on the other hand, pain information is carried less fast. Have you ever noticed that if you burn yourself or something, it may take, I don't know, it's like 2 or 3 seconds. It's perceptible amount of time to get back to your brain. So think, oh my gosh, I burned myself, or sometimes you hit yourself with a hammer and it doesn't hurt instantly. It hurts pretty fast, but not instantly. And then it gets bad because it has taken longer for that information to be transmitted back to the brain through non-myelinated neurons. They go slower. Okay, so those are two types of
So non-melanated neurons is the reason why we don't feel pain. I mean, we don't get to feel the pain right away.
Exactly. Yes. So the insulation of myelin allows the impulse to travel as quite fast, And when there's no myelin, and pain fibers don't have myelin, it goes slower. And you'll see why when we get to how those impulses travel. You'll see why it goes faster if there's myelin.
Professor, I had a question,
Yes.
kind of like off
Tam-
topic
Tamara.
though. What creates headaches? Is it like the lack of electrical impulses or what creates that?
What makes headaches?
Yeah,
A lot of different things. A lot of different things make headaches, and I'm not a headache expert, so I won't be able to fully answer your question. But a lot of times we get headaches because of muscular tension someplace, like neck. By the time I finish this lecture, I'm going to have a headache. I can tell. I hope you don't. But just keeping my head in this one position and kind of, you know, especially tilted with glasses, bifocals, and tilted so I can see the screen well, I'll get a little headache. But it's really from muscular tension. Migraines have to do with certain blood vessels contracting, and so there are all kinds of different reasons for headaches. If you just Google it, you'll find out more than what I know or what I just told you. All right. So we're going to now look at a neuronal anatomy. We're not going to look much in detail at the glial cells, but you know they serve a support role. But we want to look in a fair amount of detail at neurons. And neurons contain 3 parts that we're going to be talking about right now. Sorry about doing that. One is the cell body, and that is here in this particular kind of, I might call it a prototypic neuron. It's sort of a general conceptualization of what most of them sort of look like, and they all have one cell body. And the thing about the cell body I want you to know is that you know the parts of a cell, what the essentials parts of a cell are. Like a nucleus is an essential part of almost every cell in the body. And a neuron has a nucleus located in the cell body. And all the so-called organelles, the little parts of the cell that just make it able to sustain its own life and to replicate are contained in that cell body. Then, you okay with the cell body? If you just take all these little appendages off, you'll have a cell. Like a whole lot of cells in our body. All of our cells are a little differentiated to do the different things that they do, like skin cells versus muscle cells, but they all have organelles. So does a neuron. Okay, now we come to the specialization part of a neuron. Well, how is it different from many other cells? Well, one is it has this long appendage, and typically it is just one, and it carries an impulse. It carries an impulse, and it can be kind of short, like just one part of the brain to a neuron, you know, a micron over, or it can be really, really long. The longest axons we have in our body go from the motor part of our brain all the way down to the base of our spinal cord, which is almost down to your tailbone, not quite, but almost. So that's like a 3-foot long axon. And what happens is the activity in that certain motor area of the brain gets going, and an impulse or a bunch of impulses actually, and similar neurons are carried down to the lower part of the cord, hit another neuron, which goes from the lower part of the cord down to, let us say, our toe. Now that could be, in a real tall person, that could be a neuron that's 4 feet long. What part of the neuron is 4 feet long? The axon that's carrying the impulse. Okay, so we've got the cell body, we've got the axon. Now let's do the dendrites. The dendrites are appendages off of the cell body. And those are typically, their purpose is to pick up information from another neuron. And we'll see how that information is transmitted between one cell and another cell's dendrites. Okay, and then go down here to the other end, and here's another bunch of branches, and they have little things that are called synaptic terminals, or synaptic boutons, like little, sorry about that, sorry, like little buttons that will come right up almost to another neuron or an effector organ, could be a muscle, and form a connection. That's the basic anatomy of a neuron. And then these little things that are found along the length of this axon are myelin. They are glial cells that have wrapped themselves around the axon. Here's one, and you can see it has a nucleus. It's a cell, it has a nucleus. Its construction is sort of like, it's got a cell body and then it has like a sheet that comes out from it. That sheet is wrapped around the nucleus, but only here. Here's one, here's another one, here's another one. They're all separate cells, and they're separated. They are separated by a little space where just the axon is exposed. And this is a myelinated. This is an example of a myelinated neuron. And I'm jumping ahead, but let me just tell you why we got a nice picture here. This neuron would transmit or carry an impulse faster than a non-myelinated one by allowing the electrical current to jump from here to here, to here, to here. Now, electrical current travels real fast. It's almost the speed of light. So that allows for a faster transmission than if the electrical current simply has to travel down the length of the axon without that jumping process going on. So like I said, we'll look at that in quite a lot more detail in a few minutes, but right now the picture is so nice, I just wanted to point out the myelin. So we've got the cell body, we've got the dendrites, got the axon, and we've got these synaptic boutons or terminals. Yes.
What was the name of that cell?
What's the name of the cell? Oh, the glial cell. Are you talking about the glial cells that forms the myelin?
You said that it, the one where the messages traveled faster.
It's just a neuron. No, I haven't given it any more specialized name than that, just a neuron. Okay, let's see what's next. Okay, we're going to look at 3 types of neurons. Can we take a 5-minute break? I just have to get some water because I'm losing my voice. Okay, 5 minutes. And I'll stop recording here. Stop share. Thank you. Yes, so the information travels into the dendrite, down the axon, and out from the synaptic bouton to another neuron, or a muscle, or a gland, or so-called effector organ. Yeah. Okay, I'll bring the screen back.
Professor, you said you were going to cover later about like how myelin sheaths are like created and stuff, right?
Well, not how they're created, no, but how they function to speed up the message.
Oh, okay.
Yeah, but we have to get to the physiology of the cell first. So you got a pretty good idea, I think, of the anatomy of the myelin, what it looks like, and you also know what the function is, but you don't know how it works. Okay, so now we're going to look at 3 types of neurons, and they differ in the number of extensions off the cell body. And these are the 3 types. Multipolar, which is like the example I was showing you when we go back here, multipolar. And what that means is it has multiple projections or appendages off of the cell body. More than one, well, more than 2, multiple. Okay, so that's a multipolar, and that's kind of the typical neuron. The other 2 types of neurons are specialized, and we'll show you where. There's a bipolar sensory neuron located only these places. The olfactory epithelium, that's in the top of your nose, basically. And those we'll look at the shape of them in just a moment, but right now I'm just telling you the name. And when we see a cell body, it will have just two extensions, two bipolar, two extensions off the cell body. And that's where they're found. They're found in the retina of the eye, they're found in the inner ear, and they're found in the olfactory epithelium. So you can see they're quite specialized in their sensory. Then there's a unipolar neuron, which has a cell body with just one extension off of it. And they are found in only one part of the body. Virtually every sensory neuron in our body, except for the bipolar ones, are going to carry information from some sensory area, like a touch receptor on our finger or whatever it is, and it's going to carry it back to either the spinal cord or the brain directly. And that's what's called a first order neuron. In other words, in a pathway of neurons, a series of neurons carrying that touch information, there has to be a first one. You've got the receptor that picks up the touch, then you got a neuron, that's the first order neuron, and it carries it to the CNS. And then from that point of entrance into the CNS, it's going to go up to the brain and be processed. And there are going to be more neurons in the chain, but you've got a first order neuron. Are you okay with first order? First order neurons? Okay, so they're in the PNS, they're in the peripheral nervous system. They do enter the central nervous system, but their length is mostly in the PNS, peripheral nervous system. They're the first order neurons, and they're unipolar. They're all unipolar. Now we'll look at what that looks like. Here's a multipolar, just kind of like the first neuron I showed you. And you can see multiple extensions. And that again is a typical neuron. So if you just look at all the neurons of the brain, virtually all of them are multipolar. And they're going to have many, many connections. Here's a bipolar one, and this is specialized in this specialized receptor area. And you see the cell body, and you see that it has two extensions off, this one and this one. Here's a dendrite and a bunch of little branches of the dendrite, and here's an axon. Two extensions off the cell body. And here is a unipolar one, and it has a cell body, and then it's as if it's just a little kind of an appendage on the axon. So the unipolar neuron does have the dendrites. Those would be out in touch receptors or pain receptors or movement receptors, and they're going to carry the information in an axon that can be quite long back to the central nervous system and enter the central nervous system. And there will be, they don't show it here, I don't know why, but there will be a synaptic bouton, or probably a bunch of synaptic boutons. But the point is, one extension off this cell body. And that cell body doesn't have any connections with anything. The only thing it's there for is simply to maintain the life of the neuron. Every functioning neuron needs a cell body with a nucleus, mitochondria, and ribosomes, if you remember any of those things from biology, all those little parts that have some sort of function in a neuron, in a cell. Okay. All right, so far so good. We mostly just looked at anatomy now of the neurons and not really the functioning. And now what we're going to do is we're going to look at some physiology. And I've referred a number of times to impulses, these impulses that are carried down the length of an axon. We're going to give them a little bit different name now and call them action potentials. They are impulses, but they're more properly referred to as action potentials. And neurons are specialized for carrying action potentials. Even their anatomy is specialized. They've got that long extension called an axon that's job is to carry an action potential all the way down its length so that something can happen to another neuron or to an effector organ. And action potentials are actually changes in the electrical potential associated with the passage of an impulse down the length of an axon. So what does this mean exactly? A change in electrical potential. Well, we're going to look in more detail at other slides at what that does mean. But at this point, let me just say that if you look at the cell membrane of a neuron, there are more negative charged ions on the inside, kind of lined up along that membrane, and more positive charged ions on the outside, lined up along the membrane, and they create a potential to do something, a potential to do something. For a lot of the time, they're just sitting there in a resting state, carrying the potential. The same like if you think about a wall plug, an electrical wall plug, there's a potential to do something, but you have to make a connection between the two sides of the plug, like put a lamp on it and turn the lamp on, and now the electricity flows from one side, the charges flow from one side through the bulb, light it up, go back the other side. But before you plug it in and turn on the lamp, there's just a potential to do something. And that's what I mean by a potential. These separated charges, negative on the inside, positive on the outside, hold the potential to cause that neuron to be able to do something. And what's the something? Carry an impulse down the length. So the action potential at this point, we'll just say it is the impulse that I've been referring to. Action potentials are electrochemical. They are electric, but they also have a very important chemical basis to them. And we will look at both of those. And they do the work of the nervous system. So you have someplace between 75 and 100 billion. I still can't wrap my head around this concept. 75 to 100 billion neurons in your nervous system, most of them in the brain. Overwhelmingly, most of them in the brain, but you do have them in the peripheral nervous system too. And they're all interconnected in some elaborate way that allows us to store and process information. So the action potentials take those, they do the work of the brain, basically. Okay, now, so you know what an action potential is. You don't know you don't know how it gets started. You don't know how it manages to propagate itself down the length of an axon, but we'll get there. But we want to skip now to what happens at the synaptic, at the synapse, where the two neurons connect, or where a neuron connects with a muscle, or where a sensory receptor connects with a neuron. They all have synapses, and they all kind of work like this illustration here. So what we have in this synapse is we have a neuron that is carrying an impulse down to the synapse, and it's this one. And then we have a neuron that's going to receive the information from that synapse. And we have a space in between called a synaptic cleft. So a synapse is a connection between neurons, or it could be between neurons and effector organs, or between neurons and sensory organs. All kind of look like this. There's a presynaptic neuron and a postsynaptic neuron, and there's a cleft in between. What is in that cleft is basically the most common fluid in your body. It's essentially salt water. And the cleft is very narrow, but it's filled with liquid. And what's going to happen when a action potential arrives down here at this presynaptic synaptic bouton, which is a part of the presynaptic cell, it's going to cause those synapses to release some fluid that will travel just by diffusion, simple diffusion across that narrow cleft, and cause a reaction in the postsynaptic membrane. So let me go through that again. The synaptic bouton contains little vesicles, little capsules, membranous capsules that have a liquid in it. The liquid is called a neurotransmitter. And there are different ones in your brain and your nervous system. I should say your nervous system, because we have these in the peripheral nervous system too. And they're different ones, not too many, but different ones. And you might kind of speculate already that this is a site for a lot of medicines to have their effect. They do something that either slows down or alters the release of the transmitter, changes it when it's out here, or causes the postsynaptic neuron to take it up slower, to absorb it slower, or to not absorb it at all, or whatever it is. It's a site where a lot of medicines have their effect. anything like a pain reliever or something that would have a, you know, like the psychotropic medications, you know, the tranquilizers and things like that. Most of them work here. And it's with a particular kind of transmitter. Okay, so basically I've just defined the presynaptic membrane. I've pointed out the presynaptic membrane, the postsynaptic membrane, the synaptic cleft, and pointed out where the transmitter is. So far, so good. I did mention that the transmitter gets across this cleft by diffusion. And what I mean by that is simply the same process it would take if you could imagine just taking a glass of water and dropping a single drop of blue food coloring or any color food coloring. What's going to happen to that drop of blue food coloring in a glass of water? It's going to spread all over. And it does it, you know, slow enough for you to see the spread. It's not like it's instantaneous. And that is exactly this process that is getting the transmitter from the point where it's released at a presynaptic membrane to the place where it is received by the postsynaptic membrane. Any questions on that slide before I go away? Take it away. Okay.
I had a quick question.
Sure.
Is the synaptic bouton and the presynaptic membrane, are those synonymous? Or
Not exactly, but close, Jasmine. So here's the deal. The synaptic bouton is this whole structure here.
Oh, okay, okay.
Okay, now the presynaptic membrane is just this.
Okay,
Yeah.
okay, gotcha.
Yeah, okay, so you could say that the bouton contains these vesicles and they're actually released by the presynaptic membrane.
Okay, got it.
Then they diffuse across. I'm glad you asked that. They diffuse across and then they have an effect, which we'll go into, on the postsynaptic membrane. They cause it to do something. There's something we'll get to.
Thank you.
Yeah, you're welcome. Okay, so now let's look. Now I've got the same image here, but I've got different writing. So I'm going to just describe that process in a little more detail now. What happens is that the axon of this particular neuron that we're talking about has an action potential going down to it. And when the action potential gets to the bouton, it causes a chain reaction to occur, consisting of these different steps. First, the synaptic vesicles, they're called, these little packets of transmitter, they migrate and fuse with the presynaptic membrane. Now, so you can see this here. Here's one that's hasn't migrated yet, or at least it hasn't gotten there. Here's one that has fused with the presynaptic membrane. Here you can see it's releasing its transmitter into the cleft. And so that's the process that's being referred to here in this second bulleted area. Synaptic vesicles migrate to and fuse with the presynaptic membrane. Not all the time, only when an action potential arrives down there. Okay, next, a neurotransmitter is released into the cleft and diffuses across the cleft to the postsynaptic membrane. Now, so here we see this, here we see the diffusion taking place. And I described that with my little silly little blue food coloring example. And then what happens is that the transmitter temporarily changes this word I have not used before, permeability of the postsynaptic membrane. And what happens then is this thing that I also haven't mentioned, so this is what we have to go into detail in the next slides on. A graded potential occurs. In other words, that potential that I referred to with all the ions lined up on either side of the membrane that causes there to be a potential, electrical potential across the membrane, that changes a little bit. We'll look at the details of that. And so depending upon the chemistry involved, the change is in one direction or another. It's in the direction of causing that next cell to either be more likely to generate its own action potential or to cause it to be less likely to generate its own action potential. And so I do want to use these terms. If the neurotransmitter causes the next cell to be more likely, that thing is that what's being generated is known as an excitatory postsynaptic potential. I've used the word potential before, just about a gradient of electrical charges that hold the potential to do something. And so the something in this case is such that that next cell is more likely to generate an action potential. It's excitatory. It's more likely to do something itself. Or the chemistry of the transmitter is such that it causes that next cell to be less likely than it was at rest to generate an action potential. That's referred to as the IPSP. The postsynaptic membrane is inhibited and driven further away from the possibility at that moment of generating an action potential. Now, that's a lot to pack into this one little picture, so we kind of have to unpack it slide by slide now and talk more about resting potentials, those ions lined up on either side of the membrane and the potential to do work, and then how transmitters, affect the tendency to generate an action potential either in a more likely direction, an EPSP, or a less likely direction, an IPSP. There's only one thing I want to say before I go on from this, and then I'll answer any questions you might have. If you look at any one synapse, and you got 80 billion neurons, most of them have hundreds and hundreds of synapses on it, not just like one. It's not just one neuron communicating with the next one, with the next one, with the next one. It's a lot more complex than that. So my point in saying that is that you have 80 billion neurons, you have, I don't know how many trillions of synapses. Take any one of them. There's only one transmitter. And that transmitter is the one that's manufactured in here. And it's always going to be the same for that particular neuron. And it's always going to cause either an EPSP or an IPSP, not one or the other, sometimes and sometimes the other. It doesn't work like that. It's always going to be the same for that particular connection. Does that part make sense? Depending upon the chemistry of what the transmitter is. So if we look at these little blue dots, those are depicting the transmitters. For this particular synapse, whatever that is, maybe it causes IPSPs, maybe it's EPSPs, but it's always the same. You go to a different synapse and the chemistry is different, then it could be different. I'm looking at various states of confusion, which is perfectly fine because I think we need to get some more slides. But before I go on to the next slide, is there any question about this one?
Just one question real quick. Hi. Does the action potential help migrate it through to diffusion, or how does that work?
The action potential has just the effect upon those vesicles releasing their transmitter into the cleft.
Oh, okay, that makes sense.
Okay, now once that occurs, then the transmitter diffuses across and has its effect on the postsynaptic membrane.
Okay.
And then what happens to the presynaptic cell, if you could just think about this, here's the synapse. The synapse is actually this whole thing that we're looking at. And there's a presynaptic cell, the one that comes before and the one that carried the action potential. That's now just going to sit there and recover for a little while. It's going to have what's called a refractory period where it reformulates the vesicles. Literally what happens, if you could imagine this, going into a little more detail, but I think maybe it's helpful to just understand some of the details. You see these fusions that are taking place? That actually results in a growing presynaptic membrane. It gets bigger and bigger because it keeps adding, there's more membrane. See, here all this is going to become part of the presynaptic membrane. And then if you go back here, back to about here, what happens is this, it doesn't show it here, but this part of the Bhutan forms another vesicle and it breaks off back into here. So you're making membrane out here, but then you're taking membrane up back in and making a vesicle out of it. So there's a constant shifting of the membrane, but so that the thing doesn't grow and become huge.
Is it the
Because
same membrane going back?
yeah, exactly. Yeah, exactly.
Okay.
Yeah. And so there's this process going on to recover during the refractory period. So once that action potential has come down the length of the axon, caused this to occur, there's going to be a little recovery period. Meanwhile, you know, more action potentials on other neurons are going on, all that. But, okay, any other questions? That's a good one.
Yes. Does the Bhutan create a specific neurotransmitter for itself?
Oh, well, your question was, does the Bhutan create a specific transmitter for itself? The answer is yes,
Oh,
but it's not exactly just done in the Bhutan. It's done, you go way up to the cell body, and the RNA and DNA, you know, has the genetic code to produce this particular kind of transmitter for that cell.
and that's what makes the cell either excitatory or inhibitory.
The way I would say it is that's what makes that particular cell cause either iPSPs or EPSPs in the next cell in the chain.
Okay.
Goes back to that chemistry. And where's the recipe for the chemistry of the transmitter? Up in the cell body. And so that one particular cell, whichever cell you're talking about, is capable only of doing either an iPSP or an EPSP for the rest of its life. That's all it will do, one or the other. Not sometimes one and sometimes the other.
Because of DNA.
Yeah, exactly. Yep. Okay. So we good with that slide? I really like your questions because I think they show your thinking, of course, but I do think that's the way you get to an understanding. It transforms from just words I'm saying, which, you know, to, yeah, something clicking. Yeah. Okay, let's look at the next slide. Oh, we already looked at that one. So I think I accidentally went backwards for a moment. Okay, now, in order to understand action potentials, we probably first have to understand something called a resting membrane potential and a graded potential. And I've alluded to them, but I haven't named them or labeled them or described how they work. So now we need to get it. I think a lot of times this explanation is started with resting membrane potential. It's kind of like the starting point, and then later you get the action potentials. I'm not sure how your book did it now, but I ended up doing it like this because to me, it's sort of like you need to know where are we going and then go back and trying to understand how do we get there. And where we're going is we're getting neurons to communicate with each other and carry a message in chains of neurons and process information stuff. So the action potential is where we're going, but in order to really understand it, we have to step backwards and look at a resting membrane potential and also this thing called a graded potential. So let's do that. A resting membrane potential is an electrical potential across the cell membrane that holds the potential to generate an action potential that can propagate itself down the entire length of an axon. So that's the definition. Now let's try to make those words make some sense. How big is it? It's measured in voltage, but not, you know, in household current, it's 110 volts. If you have the extra big one, it's, you know, for charging your car, it's 240 volts. It can kill you real quick. If you grab two wires that have 240 volts between them. I don't know about 120 does kill people, but sometimes they escape that. But we're
It's
talking
the
about
amperage that
milli-
kills, right?
Huh?
Not the voltage, it's the amperage.
Oh, that's true. Yes, that's true. The electricity has to flow. Yes, exactly. In other words, if you just look at the two wires but don't touch them together or don't touch them with your hands, the voltage is there. The potential is what we're referring to as potential, but nothing's flowing through it. So this is potential. It has the potential to carry current, but not necessarily. So how big is it? It's real small. It's minus 70 millivolts. So that's 1/1000th of a volt. And then the negative thing connotes that the negative charge, the negative side of it is on the inside of the cell. And the way that's accomplished is by distributing neurons on the two sides of the cell membrane differently, in different concentrations. And I've tried to simplify it, not only for you, but for me, as much as I possibly can, by starting with the thought about the protein ions. Proteins are big molecules, and most of them are too big to diffuse across the cell. Now that's not 100% true, but the protein ions that we're talking about are large enough that they don't diffuse across the cell, and they're located inside of the neuron, and they tend to line up along the membrane because there's a charge differential across the membrane. And so they're ready to participate in this process in some way, but one thing they can't do is diffuse out. They can't cross the membrane. You might be wondering, how does a protein molecule get negative? Well, it just gives up one of its hydrogens and now it's negative. So it has a charge. It has a charge. Now there's some other ions that are really importantly involved in them, and two of them make up salt, sodium and chloride. And when you put salt in water, it breaks apart into its two ions, and they diffuse around. And in response to concentration, they tend to want to go to where they're not so many. Go from high concentration area to low concentration area so that they're diffused evenly throughout the medium that they're in. And they also are going to move around in that medium depending upon the charges that are around them. So I'm just sort of introducing some ideas with some certain chemicals that are going to be important in the process. One is sodium, one is chloride. They make up salt. And they're more concentrated outside of the cell in what we call the extracellular fluid. Extracellular means about outside the cell. And the protein and the potassium ions are more concentrated inside. Potassium can cross across, it's small enough it can cross across the membrane. The protein cannot. So I kind of think about the protein being a really principal determiner of why the inside is negative, because it's got these negatively charged big protein molecules that can't get out. And outside you got mostly salt water. Sort of just think of it as salt water. All right, so I've kind of worked my way down to here, I think. More concentrated, larger concentration of sodium and chloride outside, larger concentration of protein, negatively charged protein molecules, and positively charged potassium, the K is potassium, on the inside. And there's a significant concentration of those right along the membrane, ready to move across if they can. All right, now the membrane is what's called semi-permeable, meaning some things can get across it to some extent. It's not the same as just diffusing around the liquid. It is a barrier, but they can sort of get across, sometimes better than others, as we'll see when we get to the potentials that we're going to talk about. And this simply shows that chloride gets across the easiest, potassium the next, sodium the next, and protein the least, and in fact, not at all. Are you okay with the abbreviations, these chemical abbreviations from, I don't know, high school chemistry, or maybe you took chemistry in college too? So stop me if I'm using language that is not clicking.
Because protein is bigger, that's why it doesn't leave.
That's right. It's because of its size.
Yeah.
It's because of its size. Yeah. All right. Okay. Now this is sort of a review in a way. It shows the. By the way, I think I just saw an error. I have a P plus here, but it should be a P minus. Sorry. Okay. This is not really new information. It's just a different showing of it, really. We have intracellular concentrations and extracellular concentrations of these ions that we're talking about now. And the previous slide said this. Outside the cell, extracellularly, in the interstitial fluid that surrounds our cells, it's more or less like body fluid all over our body. It's salt water. And of course, it's got H2O in there too. But these are the ions that are going to be doing the diffusing that we're going to talk about. And then inside, we've got the negatively charged protein molecules, and we've got a higher concentration of potassium. And now, let's see, what do we have new here? Resting memory potential, you know, it's 70, I already said that before, and it's maintained as a result of the protein being trapped inside, like I indicated that before, and also the semi-permeability of the membrane to the other ions. Now, we haven't gotten into that, so that's where we have to go now. And there is this thing called a sodium-potassium pump that actively corrects for sodium that has infused inward into the cell. Now, I'm going to come back to this slide, but I want to show you the next one. This is a depiction of what I'm trying to say right now. Here is a cell membrane. Here is fluid outside the cell, the extracellular fluid. Here's inside the cell, the intracellular fluid, and they have not labeled it P. I'm sorry about that. They've labeled it A. But that is the negatively charged protein, and they did make it look big, so that part's good. And you don't see any out here. See, none. It's all inside. And it's not only against the membrane, but it tends to be attracted there. Okay, so let's take that component. Now outside, there's a whole lot of these blue sodium ions. There's one here too, just to show they do get in there. They do get in there, but they're more outside. How do they get in? There's two things that are driving those sodiums in. First of all, they can get in. The membrane is semi-permeable to sodium. We just come back here for a second. You can see here, it's not the most permeable to sodium, but it is permeable far more than to the protein. So now go back to where we were. Here, okay. So what I'm trying to tell you is why the sodium ions do get in. Even if nothing's really happening, they just will diffuse in at a slow rate. They, let's just say, leak in. And what's causing them to leak? Well, one is this thing called the concentration gradient. There's a lot of them out here and very few of them inside, and they want to go where they aren't. Just like you put the drop of the blue food coloring in the glass of water, it's going to diffuse all over. It wants to go where it's not. It wants to spread itself out. It wants to go what I would call down the concentration gradient, from higher to lower. Make sense? That's a concentration gradient. And it's not just about neurons. It's about the way it's about the way things work in fluid, basically. They want to move around and diffuse themselves as much as possible. They want to go down their concentration gradient. They don't want to go up. Now, if something went up the concentration.
Professor,
gradient-
we're overtime.
Oh, we are? Okay. Okay, now, let's go back to where we're going to cut off for the quiz. Because remember, I told you, if it's not in the lecture, it's not on the quiz. And we didn't get through this, so I'm not going to use these. We'll start here next week. But I'm going to take you up to here. So that is slide number, that is slide number 9 of chapter 4. That's as far as we'll go for the quiz. So it'll be all of chapter 1 and slides 1 through 8 of chapter 4. And I've already posted the quiz. It's supposed to open up at 7 o'clock, but I need to make sure that I don't have anything from the later parts, which I probably do. So I'm going to have to tweak some questions. So nobody's going to take it tonight, right? Is anybody going to take that quiz tonight? If you are, let me know, because I'll have to fix it for you tonight. But I figure if I get it done by tomorrow morning, it will be fine. Okay.
On
Any
the slide,
questions?
yeah, on the slides, you know how for chapter 1 you gave us some example of the quiz questions.
They're there.
They're there. Okay, cool. Okay.
Yeah. If you just keep in mind that some of them are from the later parts, and those would not be examples of what I might ask. I'm going to have an office hour, 7 to 8. You're free to drop in, and if I get groups of people, more than one at a time, I'll ask you if you want to be together or if you want private appointments, and then we can sort of set up an appointment time, hopefully within the hour, but we'll work with it. So they can be, I'm just trying to say that you can have a private appointment, but you may just have general questions and want to listen to, your peers' general questions too. And if they're fine with that, I'm fine with that. And let's see, what else do I need to tell you? I'll post the video in the morning and tweak the quiz so that it doesn't have anything that goes beyond slide 8 of chapter 4. Anything else?
Oh, Professor, are you still doing normal office hours even for today?
You mean 7 to 8? Yeah. Is that what you meant?
Yes.
Okay. Okay. And I'm turning off the recording now.